Thank you for inviting me. Great to be in Sofia. It's not gratuit, I really mean it. It's a wonderful city, what I've seen so far, and I will see a lot more. So, past, present, and future, trust it and do it. I just talked to somebody else, and I realized that in our institute, we use the central node as an indicator for doing axillary clearance only. So only if the central node was positive, we did an axillary clearance 25 years ago. We started to use the central node as indicator for an axillary clearance. So we trusted it very early on. I have no financial disclosures. I have other disclosures. I'm a male. Apologies for that. I'm a surgeon, not a gynecologist. Apologies for that. I don't wear a tie because I hate it. Apologies for that. And I'm really happy to be here. And I'm a grandfather, and that's one of the most wonderful things you can have if you at your age. Okay, I have a question for you. Here, this lady, woman, it's 45 years. She felt herself a breast cancer, and it's about 1.5 centimeter. She was small-breasted, she could feel it. The ultrasound of the axilla was normal nodes, and final aspiration showed, or core biopsy showed a cancer. What would you advise this lady? Mastectomy and full axillary clearance. Who would advise this? I think it's the wrong audience, the good audience. Who would advise breast conservation and central node procedure? Yep. All right, maybe the others don't know yet. Okay, then on histology, indeed it was about 1.6 centimeters, grade 2. And the central node had a metastasis of about 3 millimeter. The second node, or 2 nodes together, was negative. Who would advise this lady in axillary clearance? Wonderful. I'm finished my presentation. And who would advise a wait-and-see policy? Also nothing. Who would advise radiotherapy to the axilla? Yes, thank you. Okay, that's also a very good option. Okay, the old paradigm of knowing the lymph node status, of course, is it provides you with prognostic information for adjuvant systemic treatments, prognosis, the surgery, the radiotherapy, adjuvant systemic treatments, and it has said to be to improve survival. And yes, axillary clearance will provide you that information, but at what price? And I have found a nasty example over here, and you can find many after full axillary clearance. It's so interesting. This is a very old paper. It's a paper from 2008, and it was an overview analysis of many studies where patients had a negative central node, a clean central node, no axillary clearance, and a backup axillary clearance. Because in the old days, we didn't believe the central node business, so we want to prove it, so we did a backup axillary clearance. The NSABP B32 did it, and these were about 15,000 patients who had a backup axillary clearance. And the false positive rate of a negative central node, so finding tumor positive nodes in the axilla after a negative central node, was about 7%. But the occurrence of relapses of a negative central node when you leave the axilla untreated is 0.3%. So what's going to happen with this 7%? positive nodes, and the occurrence of lymph nodes later on in 0.3%. Of course, some metastases are not metastases, they don't grow out. Some are treated by radiation therapy, and many are treated by our systemic treatments, because in general patients with positive sentinel nodes are being treated. And so the axillary relapse rate is 0.3% if you leave the axilla untreated after a negative sentinel node. The risk of axillary relapse after axillary clearance is about double, so it's interesting. The next step is a positive sentinel node and leave the axilla untreated. So you have a positive sentinel node. Oh, what? I have some, hello, thing with this thing. And there are a couple of studies who studied this, the randomized study of Giuliano, you're all aware of Viviana Galimberti, the Amaros trial, and the Otozoar from Hungary. And there's all level 1 evidence that you don't, if you don't do an axillary clearance in patients with clinical negative sentinel nodes, clinical negative, but clinical negative axilla, I have to tell it right, clinical negative axilla, positive sentinel node, a wait and see or radiotherapy gives a very low risk of axillary reoccurrences. This is the 10 years update of the Z11, and you can see randomization between axillary clearance or a wait and see, sentinel node only, no difference at all. This is the Amaros trial, to be honest, my baby, randomization, sentinel node procedure. If it was positive, a randomization between axillary clearance or radiotherapy to the axilla. This is breakdown by the number of patients, almost 5,000 patients entered. 65% had a negative sentinel node, they were followed, and about 30% had a positive sentinel node, and the identification rate, you can see here, was quite high. 97% of the sentinel nodes were found. Then, of course, the randomization between those patients who had a positive sentinel node between clearance and radiotherapy to the axilla. The 5-year axillary recurrence rate of a negative sentinel node, you can see here, is all neglectable. It's really very limited. Only 25 events in over 3,000 patients at 5 years, 0.8%. Those patients who had a positive sentinel nodes, the clinical data, the age was about 56, not very young, not very old, average. Tumor size was somewhat smaller, about 2 centimeters, 70 millimeter, and about 2/3 of patients had a preoperative ultrasound of the axilla. Not everybody. Axillary clearance, about 80% had breast conservation, 20% had a mastectomy, and the vast majority of patients had any form of systemic therapy, well balanced between the clearance group and the axillary radiation group. The number of sentinel nodes was also equal divided in both patient groups, the randomized groups, and also the division of the micromets and isolated tumor cells, where the majority, 60%, had micromets in the sentinel node. This is an interesting slide because here, on average, 15 nodes were removed in those patients who were randomized to axillary clearance, and the number of positive nodes, the proportion, was about 33%. Over 4, 7, 8, and 1 to 3, 25%. You can imagine that the women who were randomized to radiation of the axilla had about the same amount, the same proportion of tumor-positive nodes in their axilla, but were left untouched. And here, the axillary recurrence rate at 10 years, and I'm proud to tell you that it's just recently published in JCO, and you can see the number of axillary events is extremely low, 7 and 11 in both groups, 7 patients and 11 patients. So extremely low positive sentinel nodes, radiation to the axilla or axillary clearance. No effect on disease-free survival, no effect on the distant metastasis-free survival. Hello. Okay. Second primaries, a little bit more. And do I do something?
No, I think from the Zoom.
Oh, do they want to ask me something? Okay. Say hi to the Zoomer. I love Zoomers. Yes, it's fine to see them. Hi, Zoomers. There is a little bit more second primaries, but we looked at it in depth, and we feel it's a coincidence because both groups got the same radiotherapy, or get also both radiotherapy, and no effect on survival. And the side effects, it was most striking that in all measurements, clinical observation, treatment of lymphedema in the radiotherapy group or in the axillary clearance group, it was double. It was twice as much. You can see the blue bars are the axillary clearance group and the red ones are the radiotherapy group. So lymphedema was substantially less after the axillary radiation therapy. And it provides an excellent control. And we can say, and many of you, I'm very happy to see that have the axillary radiation therapy as standard procedure in those patients with a positive sentinel node. There is a lot to say because we have the Z11 criteria as well. Maybe in discussion, maybe we can go into that in the workshop. So the ESCO guideline update tells us women with 1 to 2 metastatic sentinel nodes should not undergo an axillary clearance and can have radiotherapy, whole breast radiotherapy, and high tangential fields. Okay, what about a mastectomy? I will go shortly into that because that's an issue. You do a mastectomy, skin-sparing mastectomy, immediate reconstruction. You do a sentinel node and the sentinel node is positive. What to do? Do you need to do an axillary clearance for further nodal involvement? And here is a controversy because the EBCTCG overviews tells us that patients with 1 to 3 positive nodes do have an advantage of adjuvant radiation, chest wall radiation therapy after mastectomy in women with 1 to 3 positive sentinel nodes. And you can see here the not negligible differences in the breast cancer mortality even. So, yeah, there is a reason to give radiation therapy in patients with a positive sentinel node after mastectomy. But it bites, it infringes with the immediate reconstruction. In general, we don't like to do radiation therapy after immediate reconstruction, particularly with implants. And it's associated with less good cosmesis, but in itself it's possible, and local control appears not to be affected. So there is not a hard no-no for immediate reconstruction if you have afterwards an indication for chest wall radiation therapy after mastectomy. This led us to the position in our team, NKI team, if patients have a clinical node negative axilla, including a negative ultrasound, just do the mastectomy, including reconstruction and a sentinel node, no frozen section, full pathology, and then discuss in the multidisciplinary meeting what to do with the axilla. If it's low, limited disease in the sentinel node, and patients has an indication of adjuvant systemic, we don't do anything. Sometimes we give, we do an axillary clearance in unexpected, heavily involved nodes of the post-mastectomy radiotherapy. But the most important thing is if you have this management, the patient has the opportunity to share decision making. Should I have complete axillary clearance, yes or no? And that's not the case if you do a frozen section during surgery and you go immediately further with an axillary clearance. Where are we now with the lymph nodes in breast cancer? No lymph node treatment in the negative sentinel node with isolated tumor cells, micromets, and with micromets limited involvement. Here the Z11 criteria comes around. Favorable tumor characteristics. Patients are candidates for adjuvant systemic treatment and whole breast irradiation. There is, of course, no role for partial breast in patients with a positive sentinel node. We do radiotherapy to the axilla if there is 2 sentinel nodes involved, if there's a grade 3 tumor and a larger tumor. But in general, these patients are already identified pre-surgically and are being treated with neoadjuvant chemotherapy in our environment. So the lymph node treatment, axillary clearance, is for residual micromets after upfront chemotherapy and patients undergoing a mastectomy with sentinel node involvement, but here you can discuss. And here we have shifting gears. So now I have latest completely confidential news. And that's the last EBCTCG overview on axillary management, less versus more. As you can see, this is presented by Gurdeep Manu at the British Society of the breast surgeons in the United Kingdom, just last May. And about 20,000 patients have been treated in randomized trials, less versus more axillary treatment and surgery. Here are all the trials. I will summarize them. More versus less axillary treatment by nodal status in all trials. It's a bit dull what I'm going to tell, but there is no difference in local regional recurrences, nor in the breast, nor in the axilla. There is no difference in distant recurrences. There is no, even not in the node positives. And if you look, well, I will go further, there is no difference in breast cancer mortality. There is no difference in any death. And here we go to the sentinel lymph node biopsy trials, less versus more, local regional recurrences. You can see no differences. Distant recurrences, and it's very, very, very small. But the upper line, more distant recurrences, is in patients with more treatment. So here, distant recurrences, patients with less axillary treatment do better. Could be a time effect, because less treatment is, oh no, it's all randomized, of course. And even any death, more treatment, it's not significant, but at least it tells us sentinel node biopsy is completely safe if you act upon it. So the conclusions is risk of local regional recurrences in all is very low, and no evidence on effect on breast cancer mortality at all, and increased lymphedema. I didn't show you, but you trust me in this, I assume. Much more lymphedema increasing with more treatment. This is the fate of the axillary clearance at the Netherlands Cancer Institute in the past 20 years. The blue bars is no axillary clearance. And you can see also in mastectomy and also in breast conservation, it is really a very rare procedure in our environment. And you can see it, this graph ends in 216, and we are now in 223. It's now. We have to learn to our fellows the axillary clearance by the melanoma surgeons, because the breast surgeons are hardly doing it. If you want to read it all, there is a nice Lancet paper by Terry Mamounis and some others. So, sentinel node procedure in clinical node-negative breast cancer, just trust it and do it and spread the news. And I don't care how you find the sentinel node. We will have a nice presentation about the green. We use the technetium colloid. It's the advantage that you have an image, a scan before surgery, so you know where to go. You can use the blue dye. I'm not a big fan of it. I'm more a fan of the nanocol, technetium colloid. The identification rate in my hands, in our hands, is 99%. Okay, thank you for our breast cancer team, and thank you for this team next to me. And if there's any question, I'm happy to answer, but I doubt if there is any question. Thank you.